One of the things I heard recently that I found kind of shocking was that with all of the new systemic therapies that we have, and we have some incredible systemic therapies in atopic dermatitis after a very long drought, the idea came up that maybe we don't need topicals anymore, and maybe their importance is diminished in the face of all these systemics. And I was like, wait a minute, you've got this all wrong. Topicals are critical. They're so important. In fact, I would argue they're more important than ever. But Chris, when you think about topicals and their role in particularly moderate to severe patients, how do you think about them, and how do they play along with or not with systemic agents?
I think well said, Peter. Topical agents in atopic dermatitis are still foundational and are incredibly important to treating our patients. And I think in my clinic, where I use them the most are for patients that have a certain amount of limited body surface involvement despite being on our systemic therapies. So let me break that down. When we have systemic therapies, and they are very good for atopic dermatitis, one of the problems is they're not perfect for every single patient. We're not hitting EASI 100 or IGA 0 in every single patient. There are flares. We know that atopic dermatitis is a fluctuating disease. Patients have flares, and the systemic therapies, as good as they are, don't always clear patients. There is a need for topical therapy to address that remaining body surface area involvement. And today, Peter, we are lucky because 5-10 years ago, we only had topical corticosteroids to use and topical calcineurin inhibitors. But now we have a whole flurry of non-steroidal topicals, which in my opinion are changing the game, and what I like to go to first. And I'll ask you this, Peter, one of the areas where I use topical non-steroidal agents, particularly we have a few of them, ruxolitinib, we have tapinarof, we have the topical calcineurin inhibitors, we have topical roflumilast. Where I like to use them is one of the hardest areas to treat in atopic dermatitis with our current systemic therapies is head and neck atopic dermatitis. And this is an area where you have thin skin, eyelids, perfect place to use topical non-steroidals. What do you think about that, Peter?
I love that. And I think what we find is that topicals are going to be there from the very beginning, because we're always starting with a topical for the mildest patients or even for a more moderate or severe patient in the beginning. But they're, as you say, they're going to be important throughout the lifetime, because even if they're perfect on the day they come back, it's a temporal shift too. Maybe tomorrow they won't be perfect, so they're going to have these areas. And then in particular for sensitive areas around the eyes, in the folds, in the genital area, these are places where, of course, steroids can still play a role, but we have to be good stewards of that. And if we're overusing, or if they're not being able to control it in a timely fashion, then these non-steroidals are amazing. And we have now a whole palette to pick from, so we can integrate those. It's changed the game.
I think one of the populations where there really is this big uptake of topical non-steroidals is actually the pediatric population. When we think of systemic agents, as much as we've just said there's great systemic agents in atopic dermatitis, well, there's not in the pediatric group, particularly that 6-month to 12-year age group. We only have one FDA-approved medicine, which is dupilumab. So there's a huge unmet need for being able to treat pediatric atopic dermatitis. And many parents of children still prefer topicals, especially as an initiation therapy, or that first therapy that that child is going to use. And I use a lot of topicals in these patients, and I'm finding that both primarily the parents of these children, but even the older children that can speak for themselves, really do prefer having these non-steroidal agents. There is this perception that steroids are always bad, and I don't agree with that. Steroids can be incredibly important, but it's the long-term use of them that even when we guide our patients to limit the use of steroids, it doesn't always happen. And I think for me as the provider, I like that comfort, that reassurance that my patient's just not going to stay on, let's say, a medium or strong topical corticosteroid on their face or in their folds for months on end because they didn't understand the instructions, or it worked so well that they didn't think there was another option. And this is where I think we've made major headway in innovation in atopic dermatitis.
I love that. I often say there's kind of the 3 hurdles: getting somebody clear in the first place, keeping them clear safely, and then they have to be able to keep it up. And that second hurdle is a problem, where they're saying exactly as you say, oh, the mometazone's great, we use it every day. If we take a day off, we flare up. It's like, well, wait a minute, you shouldn't be using mometazone for months on end to this area, especially if it's a sensitive area. So finally, after many years of not having great tools in our toolbox, I think we really have an abundance now.
And all those tools in the toolbox, what is exciting about it, Peter, is it's not just made up magic. These are validated scientific signaling pathways that are important for barrier integrity, inflammation in the skin. We are targeting really the pathogenesis of atopic dermatitis. It's not just throwing a medicine at a disease and hoping for the best. This is targeted, rational, innovative therapies, and that's something I like. Recently, we've had a lot of talk about topical steroid withdrawal. Can you explain what that is and why that's important in the topical landscape of treating atopic dermatitis?
Sure, it's been quite a ride, right? Because I think initially, even this is now more than 10 years ago, when I first started meeting patients who came in saying that this is what they had read about it online, even I was pretty defensive at first, and I thought, well, wait a minute, this looks a lot like severe refractory atopic dermatitis. I'm not sure this is its own entity, but after meeting a few patients, I started to say, boy, there are some differences that really seem to distinguish this from even severe atopic derm. And at some point too, I felt even if they were indistinguishable, or if we could argue that this is just a refractory disease, the fact that these patients had really overused steroids and were quite concerned about them, to me, that was enough to say, even if you didn't believe in it, I agree with you, we're not going to use any more steroids. Like many of these patients have also been on systemic corticosteroids over and over. Some of these people abusing and using prednisone, not on their own fault, but because sometimes they're just miserable and they find that's the only thing that works. So 10 years ago, we had almost no options for these people. And now I'm happy to say that not only do we have great options, we have the ability to give them a menu of options and say, okay, without steroids, there's an entire therapeutic ladder that we can use. Great topicals, all these systemic agents, and I think what it means for us is that the stewardship falls upon us now more than ever before. Steroids are still the first line, and for many patients, they're going to be sufficient, right? That's all we're going to need. But for so many patients, especially those who are more moderate and severe, keeping them clear safely is really important. So using them for a burst and then taking a break, and if they're not able to do that, bringing in those non-steroidal agents. Yes, they're more expensive. Yes, they're less accessible. Yes, they're a pain in the neck for all of us to have to go through the steps, prior authorization. I don't have any magic wand. I'm doing the same kind of work, and it's brutal, but it's the right thing for the patient. At the end of the day, yes, we're trying to save the healthcare system money. I'm not arguing with that, but we have to do what's right by the patient, and to some degree, we're sort of at the mercy of our tools. And when we didn't have them, then it was easy to say, well, that's all we got. But now we do, so I think in a way, it's our duty to say, okay, we actually do have some other options.